It's time for another warm-up review. Let's get going. What gastrointestinal problem is most likely associated with each of the following scenarios? So first we have a 50-year-old woman, pruritus without jaundice, positive AMA. This is going to be classic for primary biliary cirrhosis. Next we have GI bleeding, buccal pigmentation. That's going to be Peutz-Jeghers syndrome. Next, we have a 60-year-old woman, rheumatoid arthritis, no alcohol history, fatigue, right abdominal pain, elevated ANA and ASMA, elevated serum IgG levels, no viral serology markers. So this is going to be autoimmune hepatitis. Next, we have 23-year-old woman, no alcohol history, elevated levels of LKM1 antibodies, no viral serologic markers, liver biopsy with infiltration of the portal and periportal area with lymphocytes. So this is going to be autoimmune hepatitis again. So there are a lot of different ways that you could steer you towards the diagnosis. They might give you the classic clinical presentation, they might give you the serologies, or they might give you the biopsy. Next, we have fatal disease of unconjugated bilirubin resulting from a complete lack of UDPGT activity. That's going to be the Crigler-Najjar type 1. All right, that's it for the warm-up. Let's get to that lecture now.
Over the course of the next few videos, we're going to talk about blood pressure. We'll talk about chronic hypertension and various antihypertensive drugs in the next couple of videos, but right now we're going to start by discussing how the body regulates the blood pressure. It's pretty basic stuff, but it's important conceptually. Your body needs to maintain the blood pressure high enough to perfuse the tissues and oxygenate, but not so high that it causes end organ damage. There are two main mechanisms the body uses to maintain the blood pressure. The sympathetic nervous system, which is sort of a short-term blood pressure control mechanism, and the renin-angiotensin-aldosterone system, which is more of a long-term mechanism. Let's talk long-term first. We discussed the renin-angiotensin-aldosterone system in the video on CHF, but to recap, when the kidneys sense low blood pressure at the juxtaglomerular apparatus, they secrete the enzyme renin. Renin cleaves angiotensinogen into angiotensin 1, and then angiotensin-converting enzyme converts angiotensin 1 to angiotensin 2. And angiotensin 2 has two functions. It tenses angios, so it's a potent vasoconstrictor, and that raises blood pressure. And it also stimulates the adrenals to make aldosterone, and then aldosterone causes sodium and water retention. And that sodium and water retention expands the blood volume and raises the blood pressure long-term, but not short-term. Then the short-term mechanism of blood pressure control is mainly the sympathetic nervous system. Basically, you have pressure receptors or baroreceptors in the carotids and in the aorta that sense the blood pressure and send signals to the medullary vasomotor center. And that sends a sympathetic signal that increases vasoconstriction and increases your heart rate. Let's talk about what that looks like in a little more detail. These baroreceptors are basically sensing stretch in the walls of the vessel, either stretch in the wall of the aorta or stretch in the wall of the carotid sinus. Now, when the baroreceptor in the aortic arch senses a change in the blood pressure, it transmits a signal to the solitary nucleus in the medulla via the vagus nerve. And the baroreceptor in the carotid sinus sends its signals to the solitary nucleus via the glossopharyngeal nerve. So when the blood pressure decreases, there's less stretch on the walls of the aorta and the walls of the carotid, and that decreases afferent baroreceptor firing. And those afferent nerves are cranial nerve 10 for the aortic baroreceptors and cranial nerve 9 for the carotids. And then where do the signals go? To the solitary nucleus in the medulla. Then the solitary nucleus decreases efferent parasympathetic stimulation. Now, what's the main parasympathetic nerve that slows down the heart? It's the vagus nerve again, cranial nerve 10. So this low blood pressure signal is going to decrease firing of the vagus nerve at the heart and the vasculature. And at the same time, there's an increase in efferent sympathetic stimulation. Now, which adrenergic receptors cause vasoconstriction? Alpha-1 receptors primarily. So this increased sympathetic signal will increase alpha-1 vasoconstriction and also increase heart rate and heart contractility by stimulating beta-1 receptors. And all that will raise the blood pressure. Now, this sympathetic pathway is an important response to severe hemorrhage. If you start to bleed out, the heart rate's going to increase very quickly and the blood vessels are going to clamp down. Again, this is a short-term mechanism, so your body's going to do this right away. The system can react very rapidly to hypotension. On the other hand, if the blood pressure increases, the baroreceptors sense increased stretching of the arterial wall, and there's increased afferent signal to the medulla. That leads to increased efferent parasympathetic signals from the vagus nerve to the heart, and that decreases the heart rate, so the blood pressure drifts downward. Now, one way we use this clinically is in assessing and treating a patient with supraventricular tachycardia. If the heart's going fast, you ought to be able to tell it's supraventricular because it's a narrow complex QRS. But you might not be able to say for sure what the underlying rhythm actually is because the heart's just beating too fast. Well, one bedside treatment is to perform something called a carotid massage. So you apply some pressure to the carotid bulb, and this causes increased stretch in the carotid, and that tricks the body into thinking that the blood pressure is elevated, so that the vagus nerve will tell the heart to slow down temporarily, and then you can see what the underlying rhythm is on the heart monitor. Now, the baroreceptors are also responsible for something called Cushing's reflex, or sometimes it's called Cushing's triad, or the Cushing reaction. So this is where you have increased intracranial pressure for some reason, such as intracerebral hemorrhage or an epidermal hematoma, or maybe from head trauma. And that increased pressure is constricting the arterioles in the brain and causing some cerebral ischemia. Now, the hypothalamus senses that ischemia and stimulates the sympathetic nervous system, which leads to alpha-1 vasoconstriction and elevated blood pressure. The aortic baroreceptors sense this rise in blood pressure, and the increased vagal tone leads to reflex bradycardia and some respiratory depression. So this is one of the unusual things about Cushing's reflex. You're combining hypertension with bradycardia and also respiratory depression. Normally, hypertension is associated with tachycardia. But if somebody comes to the ER with a triad of hypertension plus bradycardia and some respiratory depression, think about increased intracranial pressure. That's Cushing's triad. So that's pretty much it for the baroreceptors. But the carotid bodies and the aortic bodies also have chemoreceptors. So these are peripheral chemoreceptors, and they respond to low partial pressure of oxygen in the blood. That's the oxygen that's dissolved in the blood. So they can sense hypoxia. They can also sense hypercapnia, or elevated partial pressure of CO2. And they can sense acidosis. Now, the brain also has some chemoreceptors. They're found on the surface of the medulla. And these are called central chemoreceptors. Now, these respond to changes not in oxygen, but they do respond to changes in CO2 and pH, but not in the blood. They're responding to changes in the chemistry of the CSF and the interstitial fluid of the brain. So brain pH and brain PCO2 are both influenced by arterial CO2. So hypercapnia and increasing PCO2 will cause a response in these central chemoreceptors, but these do not respond directly to oxygen. But all these chemoreceptors aren't really affecting the blood pressure much. They're primarily affecting the respiratory rate. One of the most important ways the body can regulate the blood pressure is through vasoconstriction. Now, to understand vasoconstriction and vasodilation, we need to talk about smooth muscle contraction and smooth muscle relaxation. This is a really complicated diagram, but it's highly testable, and it's clinically relevant because it helps you understand the mechanism of a lot of blood pressure drugs. We're going to start with the end in mind and work backwards. Basically, this diagram shows a smooth muscle cell on the right, and on the left you have an endothelial cell. So let's start with the smooth muscle cell. And over here on the far right you see contraction and relaxation. Let's start with contraction. What causes vascular smooth muscle cells to contract? Smooth muscle contraction is caused by myosin phosphate interacting with actin. Now, myosin phosphate is just myosin that's been phosphorylated. And the enzyme that phosphorylates myosin is called myosin light chain kinase. Enzymes that phosphorylate things are called kinases. So myosin light chain kinase phosphorylates myosin. And then the thing that stimulates myosin light chain kinase is the complex of calmodulin and calcium. So this calcium-calmodulin complex stimulates myosin light chain kinase, which phosphorylates myosin, and that causes smooth muscle contraction and vasoconstriction. Calcium channel blockers, specifically dihydropyridine calcium channel blockers like nifedipine or amlodipine, disrupt this process. Calcium channel blockers prevent calcium from entering the cell, so this calcium-calmodulin complex can't form, and myosin light chain kinase is not stimulated. So instead of smooth muscle contraction, you get smooth muscle relaxation and vasodilation and a decrease in blood pressure. So that's how calcium channel blockers work. Cyclic AMP will inhibit myosin light chain kinase. Beta-2 stimulation and prostaglandin E2 will increase cyclic AMP, so they inhibit myosin light chain kinase. And if you inhibit myosin light chain kinase, you're going to inhibit smooth muscle contraction and cause some vasodilation. We mentioned again and again that prostaglandins keep vessels open, such as giving a prostaglandin to keep the ductus arteriosus patent in certain types of cyanotic congenital heart defects. And this is the mechanism by which that takes place. So again, three things that affect myosin light chain kinase: dihydropyridine calcium channel blockers, epinephrine acting at the beta-2 receptors, and prostaglandin E2. There's also a substance that dephosphorylates myosin phosphate, and that's myosin phosphatase. So kinases add a phosphate group, and phosphatases remove a phosphate group. So when myosin phosphatase is activated, it removes that phosphate group, which is going to cause smooth muscle relaxation. And working backwards, what activates myosin phosphatase? That's cyclic GMP. The enzyme cyclic GMP phosphodiesterase deactivates cyclic GMP by converting it to plain old GTP. So again, working backwards, more cyclic GMP is going to cause more smooth muscle relaxation. And more activation of the cyclic GMP phosphodiesterase will cause less cyclic GMP and more smooth muscle contraction. So cyclic GMP phosphodiesterase inhibits smooth muscle relaxation. Drugs like sildenafil or Viagra are phosphodiesterase inhibitors. And they result in more cyclic GMP and more relaxation. That's how drugs like sildenafil cause vasodilation. But if you want more cyclic GMP, nitric oxide works by activating the enzyme guanylyl cyclase, which in turn converts GTP to cyclic GMP. So nitric oxide activates guanylyl cyclase, and that leads to vasodilation, which makes nitric oxide one of the body's most important mediators of vasodilation. Nitrates, like nitroglycerin, work by releasing nitric oxide in smooth muscle cells, ultimately causing some vasodilation. This is why you should never give a patient sildenafil if he's also taking nitrates, because you're going to cause a double whammy, 2 hits on the same system, leading to serious vasodilation and potentially dangerous hypotension. Working backwards from nitric oxide, you can see that L-arginine or levoarginine is a precursor to nitric oxide. There's an enzyme inducible nitric oxide synthase, or INOS, that converts arginine to citrulline plus nitric oxide. And there's lipopolysaccharide, or LPS, that stimulates nitric oxide synthase. This is how gram-negative bacteria cause vasodilation and sepsis via these lipopolysaccharide endotoxins. And then finally, over in the endothelial cell, you see that vascular endothelial cells have a nitric oxide synthase called eNOS, for endothelial nitric oxide synthase. And this isn't inducible. eNOS is constitutively expressed. It's always expressed. So eNOS converts levoarginine to citrulline plus nitric oxide, and then the nitric oxide seeps over to the adjacent smooth muscle cells, and it causes vasodilation. And there are a bunch of things that activate eNOS: bradykinin, acetylcholine, alpha-2 agonists, histamine, serotonin, and shear stress. So all these cause vasodilation by increasing intracellular calcium and increasing generation of nitric oxide. Even serotonin, which we think of as a vasoconstrictor, it does stimulate this endothelial NOS. So there are lots of different drugs that affect this pathway at different places and lead to vasodilation and smooth muscle relaxation. Now this pathway is very high yield for your exam, especially with regard to nitric oxide. Another important chemical besides nitric oxide that mediates vasodilation a little bit is called atrial natriuretic peptide, or ANP. So it's very similar to the brain natriuretic peptide, or BNP, that we talked about with CHF. ANP is a hormone produced in the atria of the heart in response to increased atrial volume and increased atrial pressure. So the atria gets stretched, and then they start releasing ANP. And just like BNP, ANP has 2 effects. It's a vasodilator, and it's also a natriuretic peptide, so it causes a diuresis of both water and sodium. And it does this by acting on the afferent and efferent arterioles in the renal glomeruli. It constricts the efferent arterioles in the kidney, and it dilates the afferent arterioles, which is going to increase the GFR and promote diuresis. So you can think about ANP counteracting the effects of aldosterone. Instead of retaining fluid and expanding the intravascular volume and raising the blood pressure, ANP causes diuresis and helps to reduce the blood pressure just a little bit when the atria become overfull. And you may want to write in that both ANP and BNP act on the same receptor, which is called natriuretic peptide receptor A. There's also NPRB and NPRC, but the main one is NPRA. So NPRA, or natriuretic peptide receptor A, is a transmembrane receptor that has guanylyl cyclase activity. So when ANP or BNP bind the receptor and activate the guanylyl cyclase, it results in increased cyclic GMP, and that's how ANP and BNP cause vasodilation. That fact does get tested, so make note of that. Even though the kidneys and the sympathetic nervous system regulate the blood pressure globally, certain organs can influence blood flow to themselves through a process called autoregulation. So let's consider how autoregulation works in 2 organs, in the heart and the lungs. In the heart, you have local metabolites like CO2 and nitric oxide and adenosine that determine whether the coronary arteries and the arterioles are constricted or dilated. So if the heart tissue is underperfused and CO2 starts building up, the coronary arteries are going to be dilated to bring more blood to the tissue. And then nitric oxide, that important vasodilator mechanism, also helps to maximally dilate the coronary arteries. Now, this is kind of a confusing point for a lot of medical students because we give nitrates like nitroglycerin to treat angina. So angina is due to myocardial ischemia, an inadequate oxygen supply, right? Well, a lot of students think that nitroglycerin improves myocardial oxygen delivery by dilating the coronary arteries. But that's really not the case, because if your heart is starving for oxygen, then your coronaries are already going to be maximally dilated. It doesn't matter what you give the patient, you're not going to be able to dilate those coronary arteries anymore. They're already maximally dilated. So, how does nitroglycerin relieve angina then? Well, nitroglycerin causes systemic venous vasodilation. That's going to reduce the preload to the heart, and ultimately this decreases the myocardial oxygen demand. Now, don't get confused by that mechanism. Sublingual nitroglycerin reduces preload, and that reduces oxygen demand. It's definitely high yield, and I guarantee you're going to be pimped on that during your internal medicine rotations. And then, how do you think adenosine would affect coronary blood flow? Well, think about where else in your body you see adenosine. Well, it's part of ATP, right? So your body senses adenosine as a starvation molecule, so to speak. The body sees adenosine around. It's telling your body that you've broken off all the phosphates from that adenosine molecule. You've used up all your adenosine triphosphate, all your adenosine biphosphate, even monophosphate. So if you have just plain old bare adenosine, that communicates an energy-starved state and a need for oxygen. So adenosine is a very, very potent vasodilator. And that's why patients get that flushing reaction when you give a little push of IV adenosine in the treatment of supraventricular tachycardia. Then the only other thing I want to mention about autoregulation is that hypoxia in the lungs causes vasoconstriction. We talked about this back in pulmonary. Anywhere else in the body, hypoxia causes vasodilation. So if you have myocardial hypoxia, your body reacts by increasing the diameter of the coronary arteries to get more blood and more oxygen to that area. But in the lungs, this would be counterproductive. You would be increasing perfusion to areas of the lung that are not very well ventilated and not well oxygenated. And then that poorly oxygenated blood would be circulated throughout the rest of the body, so that's no good. So instead, the lungs represent a self-sacrificial system that benefits the rest of the body. Instead of hypoxia causing vasodilation like it does everywhere else, hypoxia in the lungs causes vasoconstriction. So you clamp down the vessels going to that poorly oxygenated lung tissue. That's going to deliver more of the pulmonary circulation to the well-oxygenated tissue. Now let's go over the end of session quiz. All right, the first item says, outline the mechanism by which the kidneys regulate blood pressure. So first, the juxtaglomerular apparatus senses low blood pressure, and that stimulates the production of renin. The renin converts angiotensinogen to angiotensin 1. And then in the lungs, angiotensin 1 is converted to angiotensin 2, and the enzyme that does that is angiotensin-converting enzyme. And then angiotensin 2 causes direct vasoconstriction by acting on angiotensin 2 receptors, and it also stimulates aldosterone production by the adrenal cortex. Then aldosterone is going to circulate back to the kidneys and facilitate the retention of sodium and water, and that's ultimately going to increase the blood pressure. Next, what substances act on smooth muscle myosin light chain kinase, and how does this affect blood pressure? We said that dihydropyridine calcium channel blockers, epinephrine acting at the beta-2 receptors, and prostaglandin E2 all cause relaxation of vascular smooth muscle, and that leads to vasodilation. And generally, vasodilation leads to a decrease in blood pressure. But remember that when epinephrine activates alpha-1 receptors, it causes vasoconstriction. So the effect of epinephrine is very tissue-specific. In the coronary arteries and the arteries to the skeletal muscle, beta-2 stimulation causes vasodilation to send more blood to the heart, send more blood to the muscles for fight or flight. And at the same time, alpha-1 stimulation in the arteries going to the skin or the GI tract will vasoconstrict and shunt blood away from those tissues. And the last item says, describe the chain of events in which hypotension causes a reflex tachycardia. So low blood pressure results in less stretch of the carotid sinus and the aorta, which causes less stimulation of the parasympathetic afferents, the glossopharyngeal nerve, and the vagus. And then that signal gets transmitted back to the solitary nucleus of the medulla, and that triggers decreased inhibition of sympathetic output. In other words, there's going to be an increase in sympathetic output as well as a decrease of parasympathetic output. And that combination leads to reflex tachycardia. That's it for now. I'll see you next time.